Okay, so we're going to start with doing a role play of the session 1. And I call session 1 the funeral session. The reason I call it the funeral session is because the state of mind I want to create in the family ultimately is one of grief about the possibility of losing their child to anorexia. But at the same time, I want them to feel contained in the sense that a supportive, either religious person or family might have in terms of containment in the context of not overwhelming grief. I want to take some of the overwhelmingness away, but I still want the worry present. To do that in session 1, I want to engage the family as one wants to in any therapy. I want to obtain a history of specifically how anorexia nervosa has been affecting everyone in the family. In doing that, I will assess how the relationships in the family are being affected or changed as a result of having anorexia part of what the family's going through. And I'll try to look for opportunities to specifically address any feelings of guilt or blame that the parents feel. Just a moment about engaging. One of the things that as a therapist, regardless of treatment, I want to do is I want to get people in a therapeutic window as a therapist. And we talk about therapeutic windows with medication. You got to get a dose level up, and you don't want it too high or too low. It won't be effective. The same is sort of true in therapy. You don't want to have people so under-motivated or anxious about a problem that there's no energy in the therapy. And you don't want them so overwhelmed and completely anxious that they can't even think in the therapy. So I'm wanting to create, my metaphor here is a window of sufficient anxiety that you want motivation for change and yet not feel overwhelmed. So again, with kids, typically teenage boys coming in for therapy, they're always way down here. They never, ever want therapy, almost ever. And so I'm always wanting to get them up here. But if I have a parent whose child is dying of cancer, their anxiety is way up here. So I'm going to want to try and bring them down. So in this instance, I'm wanting to assess where they are in that window and try and get them in the right place. The interventions I'm going to be using are these 4. Greeting the family in a sincere but grave manner. I know this, I feel like a bit like a director, but I want to communicate to the family how concerned I am about them, but I also want to keep them worrying a little bit. So in strategic family therapy, there's something called a double bind that you're trying to actually create. And this greeting and this period of this whole session is a bit of a double binding session because we're trying to, on the one hand, tell them they've got a life-threatening and horrible problem on their hands. On the other hand, we want to sort of hold them together. And I want to have the family feel warmth from me and caring, but I want them also to be anxious. So this constant sort of dialectic between those two sets of feelings. I want to do this separation of the illness, this externalization, we talked about that earlier with the spiders and the aliens and Ed and so forth. And then I want to use the knowledge that I have about anorexia and its effects to, and also what the family tells me about their own experiences with their daughter, about how bad this can get and create what I call an intense scene, meaning a sort of strongly emotional awareness about the seriousness of the problem at hand. And in so doing, I want to then have created an emotional hook on which to hang my request of charging the parents to take charge of a very difficult problem, which they have already been trying to do, which is to get their child to eat more than she wants to, and then to persistently go after that. So those are the things I'm going to do, and I'm going to illustrate each of these interventions, and as I illustrate them, after I've done them a bit of them, I'm going to stand up and talk to you about what you observed and so on. I'm going to just let the introductions of the family happen the way they happen would happen in therapy, though. So when I sit down, that means I'm in therapy mode. Hi, everybody. It's nice to meet you. I'm Dr. Locke. I'm going to be your therapist working with you here. I'm someone who's been doing work with families with patients with eating disorders for a while now. So I hope I can be helpful to you. And I want to start, though, just if I could, just to have a little few minutes to hear about each of you and introduce yourselves and tell me what you'd like me to call you during the therapy and a little bit about your interests. So anyone can start.
I'll start. My name is Brianna.
Brianna.
And I'm the mother.
Okay.
Yes, I'm a teacher, but stay home a lot.
What kind of stuff do you teach?
I teach elementary students.
What age group?
Kindergarten.
Kindergarten, okay.
Yes.
How long have you been doing that?
For 5 years.
Okay. And you like it?
Yes.
Do you have other interests?
Yes, cooking, exercising, taking care of my children.
Okay, good. All right.
Well, my name is Vivina.
Hi, Vivina. Is that what you want me to call you?
Yes.
Okay.
I work as a licensed mental health counselor. And basically I work long hours. I do some teaching on the side, so I'm really not home much. So my partner here really does most of the rearing for the kids.
Okay. And do you have other interests outside of work? Sounds like you're awfully busy.
Yeah, I like to read.
What kinds of things?
We like jogging sometimes. Any type of literature. Bestsellers are usually fun to read.
Okay, good. All right.
I'm Sarah.
Hi, Sarah.
Hi. I'm 18 and I'm just getting ready to graduate from high school in a couple of weeks.
Congratulations.
Thanks. I also really like to cook, and I'm still trying to figure out what I want to study when I get to college. So.
Do you know where you're going to college?
Yes, I do. I'm going to FIU.
Oh, you are? Okay.
Yes.
So that's a good school.
Yes.
But you know what you're going to do. What has been your main interest in school now?
I really like history a lot, and I've been studying French for a really long time, so that's something that I might be interested in doing.
Okay. Okay, good.
Hi, I'm Maya,
Hi, Maya.
and I'm 15, and I'm here because they told me to come here.
Okay.
Sorry, I'm here because they told me to come here.
Okay. What do you do besides school?
Just study and...
Well, school.
Yeah.
Do you have a favorite subject?
Yeah, I like math.
Okay. What math are you doing now?
Calculus.
Okay, good. All right. Do you have an idea what you want to do?
No, I'm not sure yet.
Okay. Thanks. All right. So, that took about 5 minutes, maybe. I've learned a lot actually in 5 minutes. I hope you have too. So what I've learned is, first of all, that both parents care something about fitness and health. There is some focus in the family on food because there's mentioning of cooking and it being an interest. We have a mental health provider here, which is always a worrying thing. It's the only thing worse is if it's a doctor, then you really want to get out of the room. But I mean, truly, they're hard to work with at first. You have to really be really practiced about it. But the things I've observed is the family's pretty calm. They're not disagreeing with each other. There's not a lot of overt expression of feelings yet. And you would be surprised how quickly you can see this. I also notice the parents are sitting next to each other. Whether that means anything yet, time will tell. And the siblings are sitting next to each other. I like seeing that because looking at a structure in the family, this is the kind of structure you actually want to have. You want the parents working together and you want the siblings working together. Often, you will not find that to be the case when you actually are seeing a family. The parents may be sitting on either side of the patient and the sibling off to the side more. So I point that out because we can only illustrate what we can illustrate, but they've given us the impression at this point that in the scheme of families, they have some concerns, and they have many other things, but there don't seem to be a lot of tensions, overt ones. But we'll see. So now what I'm going to do is I'm going to start talking with them about how anorexia got started in the family. So this is obtaining the history of how AN affects the family. And in getting that information, I'm going to be trying to gather information about how Maya actually has changed since she got ill, because that's going to help me externalize, right? Because she's no longer the same. All right. So let me ask you, I'd like to know if you could go back in time a little bit and tell me how or what you first remember about getting worried about Maya's weight or her developing anorexia.
I think it happened a few months ago. We noticed that she's stopped eating so much and participating in dinners and trying to be avoidant of mealtime.
Okay, so when was that?
About 4 months ago?
I'm saying probably. I think I started noticing a little after she did. She kept mentioning it to me, and I kept saying, well, she's probably just not hungry. And then she kept persisting on it until finally I realized, yeah, she's really avoiding coming to the
And she's
dinner
losing
table.
weight, and she's looked different.
So the first thing that you remember is her trying to get out of meal times, and then noticing weight loss, and then you noticed it after your partner told you that.
Yes.
Okay. Did you notice anything like that, Sarah?
Yeah, sometimes after school I would see if she wanted to go get like ice cream or get coffee or something before going home to start homework, and she wasn't ever interested.
So you guys used to do that before?
Yeah, maybe like right when I got my license a few years ago.
So you go to the same school still? Okay. So you noticed that, okay. Do you remember that Maya at all? 3 or 4 months ago, getting involved with meals time and...
I've just been really busy with school. So just, being in my room, doing my homework, just don't have as much time as I used to go with my sister.
All right, so I'm going to interrupt for a second. I'll continue with this. But what I'm trying to show you here is a technique. It's where I'm doing a form of circular questioning, where I'm trying to build on the story that each person is telling. And I'm trying to help the family, probably for the first time, this has been my experience, actually talk together and agree on a sort of course about what's been happening. They may have all had their private observations, and maybe the parents have talked some, but usually not the whole family together. And there's several other things I would have noted here. One is that these two parents, again, are not in conflict with each other, or not expressing conflict. There may be at different stages of understanding, but this mother is on it, and this mother is also agreeing that there's a problem. It took her a little longer. And the way that they're interacting with each other is supportive and caring. So I'm thinking that they may be working well as a dyad, even under the stress of having Maya being ill. Also, Sarah, is a caring sister, as she appears to be. And sometimes older sisters, I guess sometimes, they are not always nice. And that's been my experience with some families. And she actually was driving her sister to school, or from school home, and was worried enough about it to begin to offer her some kind of food. Now, part of me is happy that she cared, but part of me knows that she getting involved in trying to refeed her sister is probably not going to go well. That this really requires parental authority, not sibling support. Does that make any sense? So I'm going to keep my eye on that piece over the course. So let me just continue with this for a little bit. Okay, so what happened next after you noticed that she was skipping meals and not eating as much?
We also like to cook as a family, and especially Sarah, but she seems to be avoidant of that as well. and just goes to her room, says, I have a lot of work, and then goes to her room to finish the work.
So she doesn't participate in the cooking of the meals?
Yes, yes.
See, I just think that that's just part of her being an adolescent, and she's, you know, in her room a lot, which I think is just typical adolescent behavior.
Mm-hmm.
I don't necessarily see it the way she does. Yes, I am concerned. I think that she has lost weight, but I just think that, you know, she's going to go through that phase and then eventually reintegrate the way we always do with cooking.
Okay. And so did you also notice this with your sister, that she wasn't going to mealtimes, whatever the reason might be?
Yeah, she's been making a lot of excuses, usually related to getting work done or being really tired or saying that she had a really big lunch and just not being interested in eating at home.
And did you start not wanting to cook with the family?
Yeah, I just trying to get my work done and trying to watch my weight and, you know, not eat as much, so.
Okay. What happened next?
We also like to jog together, and Maya likes to exercise too, but we've noticed an increase in the exercising. And in the evenings when we're eating dinner or we're cooking, she'll sometimes either go to her room or she'll go out on runs, and it will be consistent in a lot of times and for a long period of time.
So in addition to eating less, you've seen her exercising more and longer, more often? Okay. And you saw that too?
I guess I have to agree with that. I mean, Sunday mornings, I'm usually the only one that goes out for jogs because they're usually like to sleep in. And she's been getting up with me more often.
Okay.
I go out for,
So she's been going with you? And,
yeah,
okay,
which
okay.
I find unusual because she's always used to be a sleeper.
So that's a change?
Yeah.
Okay. All right. What happened next?
Sometimes I observe her measuring her food.
Oh.
If she eats a meal in the house, I will see that she takes her food and she'll separate it a little and measure everything out.
Okay.
So I'm a little worried about that because
When did
I've
that
never
start?
seen that before. About 3 months ago.
So pretty soon after she started doing other things that you noticed? Uh-huh. And okay. And how much weight has she lost?
What do you think?
I don't know. 15,
Yes.
20 pounds?
So the pediatrician hasn't told you how much she's lost?
You're the one that's been going to the appointments. I'm
Yes,
not sure.
it's about 15 pounds. Yes.
Okay.
And she's a small frame to begin with.
Were there any other concerns that the pediatrician raised? Any other changes?
Just the stress level. I know that she's having a lot of work being in high school, and he's concerned about her stress level, about having too much work and too many demands on her.
Okay.
She's in a lot of clubs and different teams at school.
Do you see that as a problem, Maya?
I thought they'd be happy that I'm being fit and, you know, eating healthy. That's the example they set for me.
And what about for the activity level at school in terms of work and clubs and stuff?
I don't know, I think it's good to be busy and
Have you been doing
know,
as much of that
productive.
lately?
the,
You're doing more of it or less of it? Has it
yeah,
changed?
the same, I guess.
Have you noticed it's gone up or down in the last month or so?
Her weight?
No, her activity.
Oh, her activity.
At school, her
It's
social
been,
things.
yes, a little bit. I think that she's put herself more into doing the work there, more demanding of herself
Okay.
to go.
Okay. All right. So I'm listening.
Just to remind you guys to speak up a little bit, folks at the back, find it hard to
It's tempting because, as you can tell, I hope, they're falling under the sway of my therapy, whether they like it or not. And so it's quite intimate up here. You may not be able to tell it, but we are actually having quite an intimate conversation up here. I hope you can. So it does, voices tend to drop off because they're not talking to you. they're talking to me. And I can hear them, I'm right here. So, but do remember normally I don't have microphones and all this stuff around me. But just a couple of points here. What the family is telling me is really a typical story. So here's a kid who was doing okay. She starts dieting. She gets involved with it in a way. She starts trying to avoid meals. She no longer wants to participate in the family cooking. She may want to do her own cooking. We didn't hear that yet, but she may. She's added exercise in and more intense exercise. Probably there's exercise that they don't even know that's going on in addition, but they're aware of it already. Parents, mom has really very clearly got it. Dad is, the other mom is sort of functioning with a reluctant acceptance that there's a likely issue here, but the data is building for her as well. Sister seems to be pretty aware that there's a problem and is acting supportively. And I can, so right now we started to talk about medical things. And the reason we did that is I wanted to get a sense about how worried the family was about the effects of starvation on their child. So that's what we're sort of moving in here now. She's lost 15 pounds and she was already small to begin with, her mother says. So likely is that she's lost 20–25% of her weight, what she should weigh. So she's probably pretty medically fragile. Now, I don't know how knowledgeable the pediatrician is that she's working with, but I was pressing to understand whether or not the pediatrician was worried about her medical condition. So I'm going to go into that a little bit more now. So when you met with the pediatrician, you were there, right? You weren't able to be there.
Mm-hmm.
So what did the pediatrician tell you about her heart rate and her blood pressure?
He said that her heart rate was okay, but her blood pressure was a little low.
Okay.
He was a little concerned over that.
He was?
Yes.
Do you remember what he said about why he would be worried about that?
He noticed from the year before that she had lost a significant amount of weight. And so he mentioned that to us, and we started that conversation after that visit.
Okay.
About coming in and meeting with you.
And Maya, what did you think about what the doctor had to say?
Nothing, he's just doing his job, I guess.
So were you worried that he thought your blood pressure was low?
No, I think it's normal when you're smaller to have lower blood pressure.
Okay. Did he make any recommendations to you?
He recommended that we come and see you and to have her evaluated differently.
Okay. And did he make any other recommendations about weight gain or anything like this?
He advised that she sits in on the meals and eats a meal, and that we see her eating the meals.
And did you try that?
Yes, we try, but it's still difficult when she says, oh, I have so much work to do, and she's an adolescent and she wants to have her time in her room. So we want to respect her as well.
Okay.
Can't force her.
Mm-hmm.
I mean,
So what have you tried to do to get her to eat more?
We've tried to make her favorite foods, and she'll eat a little, but she won't eat like she used to eat. She'll have a bite or so, and then, oh, I'm full, and then she'll go to her room.
And then what do you do when she goes?
We'll save it for her for later in hopes that she will come back and eat it, but she won't.
Okay. And anything else you've been trying to do?
we've tried going out to dinner.
Uh-huh.
We've tried doing that.
And what happened when you did that?
She orders a salad and nitpicks in it and
Okay.
leaves most of it.
What do you do after that, when she does that?
Well, we get on her for it, and then she says she'll take it home and eat it later. I never see her eat it.
Mm-mm, she won't eat it.
Okay. Okay, so let's just stop for a minute and interrupt. So this is a fairly typical kind of scene too. I mean, here are these parents. They're having a struggle between adolescent developmental autonomy and its appropriateness, and worry about how much she should be eating, and no idea how to help her eat more. I mean, they have ideas. They've tried a couple things. Doesn't sound like they tried any of them very consistently, which would be typical. They made her favorite foods, but then she doesn't eat it, nothing happens. And then they go out to restaurants, and she orders, and then she promises she'll eat it later, and she doesn't, and nothing happens. And so there's a really good reason why she's not eating, because the parents' efforts aren't strong enough and consistent and persistent enough to actually confront and change the behaviors. And we'll get into externalization now as trying to understand and help them see why they're struggling. But I want to say something about Maya. Maya is doing a great job playing this role. What have you noticed about her? I mean, she is very good at just being a foil. She just everything just sort of washes off of her. Like, cannot be bothered. I've got my work to do. This is all hubbub about nothing. The doctor is not really an expert on blood pressure. I am. I mean, this is very, very typical of what I would expect to see in a well-behaved, and I put that in quotes for sure, anorexic. She's being extraordinarily effective by being like this. This is one of the cleverest strategies that a kid with anorexia can have. One that really yells and screams and makes a big fuss. Parents can see that's a crazy behavior, and they can quickly get on the idea that there's a problem. One who appears so serene and rational and is doing calculus, this is hard for parents to believe. Now I want to point out something else, that Brianna, playing one of the mothers, is constantly checking in with her partner. She's looking at her, she's checking to make sure that what she's saying, or appears that she's making sure that what she's saying is going to be in agreement. So she's doing a behavior that you want to see in a couple, that will check in with each other. And also, Viviana is also doing that too, although to a lesser degree, but she's also more responding. And I will often, to what Brianna is saying, because Brianna is the lead, right now, she's the leading parent of worry. She's got the leading edge of worry in the family. If you kind of put the leading edge of worry, you have her in front, and you would have maybe Sarah and you, and then your way tailing off in the end. And so, and there usually is one parent like that, sometimes both, but the leading edge of anxiety is there. Okay. I would go on with this review of what the family's been trying to do and their effects for a good 20 or 30 minutes of the session. So we won't be able to do that here, we don't have time. So I will now move to this orchestrating of an intense scene, which I will build on after I have done a little in the context of separation. Okay, so you've been telling me an awful lot of things have changed with Maya over the last 3, 4, 5 months. It sounds like she's exercising a lot more. She's much more preoccupied with food and eating and weight. She's constantly trying to stay out of the family and being at school. She seems like she's even getting more driven about her work at school. She's more irritable at times, and she doesn't do what you've asked her to do around eating. And so these are big changes in the last few months that all of you have observed. And although Maya might not agree with me when I say this, and I say it because I really want you to understand, and I hope the part of Maya that isn't really lost in anorexia, although there's a good bit that is, will hear this, and that is that she's really developed a serious problem now. She's lost 15 pounds, her blood pressures are dropping, soon her heart rates will be dropping. And she's in more and more physical and emotional compromise each day that goes by. You've seen this, the two of you actually have both agreed there's a problem and you tried to do things about it. It sounds like you've had really good ideas, the idea of trying to get her to eat more and making foods for her that she will like and trying to take her to places that she'd enjoy being at, and restaurants and so on. But none of that has worked yet. And so you're kind of lost, it sounds like. And I just want to help you a little bit to think about that. And Sarah, it sounds like you also are worried that you've kind of already pulled in, you know, spend extra time with her, trying to get her to go eat with you, and it sounds like also that you're worried about her, and you've noticed all these things too. Now, Maya, I know you may not agree that they should be worried, but I am worried because what happens when someone develops anorexia nervosa is it changes a lot of things about their physical, emotional, psychological, and social health over time. And I just want to talk a little bit about that. When Maya was well, do you remember Venn diagrams, everyone? Yeah. So when Maya was well, this was her, and she was, you know, she was this really, and still is, smart, capable, caring, hardworking kid. As she began to develop anorexia, and this is anorexia right here, and it's gonna, these are gonna overlap like this, and as the anorexia begins to overlap, she's still there, but a lot of what she's doing now is focused more on these other things. So that drivenness, that perfectionism, that hardworkingness, that has helped her be such a good student and an otherwise pretty great person, has really now interfering with her life because she's focusing on losing weight and on over-exercise, and she's gotten physically quite vulnerable now. And we really need to find a way to get her rescued from that and pull those circles apart again. When you met with the doctor, did he tell you what could happen if she stays ill?
He started to say if she loses more weight that she could risk becoming more sick and more chance of getting fevers and flus and really injuring her heart, and he advised her to stop exercising. And
did you hear that too?
I remember you saying too something about maybe she may need hospitalization or something like that.
Yeah, so if you do get to a point where your weight is so low and your heart rate drops to a certain point, because your heart is it needs to beat at a certain rate, otherwise it risks not keeping its rhythm. And what the heart does is, when you don't have enough energy for it by eating enough, we're mammals, so we have to eat at regular intervals, or we start using our body for fuel. And your heart is a muscle, and a muscle is one of the big sources of fuel, and your body starts eating your heart, essentially. And when that happens, your heart tries to slow down to conserve energy, so your heart rate goes slower and slower. And you might have also noticed that she's cold a lot, and that's because her body can't keep the body temperature up. You need to be eating in order to be able to keep your body temperature up. And so she's going to be cold when the rest of everyone else is warm. And she also may be up in the night scurrying around, because when you actually get more activated sometimes when you get really, really thin, because your body's actually trying to look for food. I don't know if you've noticed that, Maya, that you're sometimes awake at night?
Yes.
You have? Okay. This happens with starvation in the acute phases, and you can have to go to the hospital just to make sure that you're safe. But even if you go to the hospital, that doesn't get you out of the woods, because actually what happens over time if you stay so thin is you lose your period. And I don't know if she's lost her period, has she?
I haven't even asked you, Maya.
It's not as regular, but I still get it.
Yeah. So chances are good that she has mostly lost it or will lose it. That means she's not making hormones that her body needs to actually deposit calcium in her bones. And that means her bones are becoming fragile. And you've seen pictures, I'm sure, in science about what happens to bones as people age. Particularly, they get really thin looking and then they break, osteoporosis, and particularly the back vertebrae tend to collapse and you get that hunched over look. That can happen at very early ages right now. It's already happening if she's lost her period. And I want to point out, during adolescence is when you actually put most of the calcium and mineral into your bone for your life as a woman. That's when you do it. So that's one. People have an increased mortality risk of about 1% a year, each year they stay ill. Now, she hasn't been ill yet for a year, but and that's over what it normally would be. So if she stays ill for 5 years, 5 years, 5% more increased risk. people die of cardiac arrest and of suicide. Because after a while, this is a very critical illness. And Maya, you may not be able to say this yet, but I'd be interested to know if you could, which is, it's very hard to please anorexia, the thinking. You can never quite exercise enough or eat just anything less. If you eat less, it's better. So if you eat anything, it's a little bit of a critical thing. Do you have that feeling?
Yeah, like I think about it all the time.
Right. Whereas you used to think about other things. Right? So you can tell that's a pretty intense kind of conversation to be having about the health consequences, the emotional vulnerability, the possibility of suicide and cardiac arrest, eating your body as fuel, particularly your heart. These are vivid, meant to be strong communications about how serious the illness is. So I'm orchestrating this intense scene. That's what's happening here. And I've tried to use the information that they've also given me about Maya's own behaviors and how it's changed. Now, Maya told us a little bit about her own internal experience. Often you will not get that in a session 1. They just won't tell you much. But sometimes they do. And I hope you saw how I did it, because I externalized for her too. I said some part of you may be able to hear through the anorexic fog, and some part of you may be able to remember or think about how things have changed. So I'm trying to protect Maya also from having a sense of being a bad person for having developed anorexia. I don't want her to feel that, and I don't think she does. I think she feels some support. So then I'm going to go to the last intervention, which is charging the parents with the task of refeeding. So I want to say something to the two of you particularly. I want you to understand, I'm saying everything I've said about how serious this is. I want you to know also, though, that I know that as parents, you can help her. I also have heard that you've tried and you've had really good ideas, but you haven't had much support in thinking about how best to carry that out. And Maya, because of the lost place she is in with anorexia nervosa, isn't really able to be much of a help right now, and isn't really able to go along with things like she normally might have in her life. So I need the two of you actually to step up here and really learn how to help her eat enough to gain the weight she's lost back and change what she's doing in terms of her exercise so that she's safe. Otherwise, she will end up in the hospital, or she will end up with really these chronic health problems. And Sarah, she needs you very much too, not to get involved with the food. She needs you to actually help her put up with what will be a very hard thing for her to do, as you probably already know. She's not going to like having to change what she's doing. And if you can be and think a good sister to her and think of ways to, not around eating, but other things to do with her, maybe take her on a drive after when she's feeling stressed out, talk to her, play a game with her, whatever things that might be normal and supportive that you would like to do for her. Does that make sense to you? Do you think you could do that?
Yes.
So what I want you two to do, and I know this may be a big demand on the one hand, is to think about how you're going to do this. And to get started, what I want you to do is the two of you together to plan a meal and bring it to our next session, which will be on Friday. And I want the two of you to decide what the meal will be, and that you think it'll be a meal that will help Maya start restoring her weight. Okay? And it needs to be a meal that you can just bring in. I don't have a kitchen or anything. We'll have a table and everything, but I don't have you can't heat it or anything.
You're going to bring food here?
Yeah, right. And we're going to have a meal together. So, and we'll see you on Friday. Okay? Thank you. All right, good. Okay, so I lower the boom without much time left in the session for a couple of reasons. on the one hand, I don't want a lot of questions about how to do this right now, because my goal here has been to do exactly what I've done, which is engage them and to get them worried enough that they're going to actually come back. I've also asked them to do something, which is bring a meal next time. And the second session is a family meal, which we won't have time to illustrate, but which is an opportunity to do treatment in vivo experiences with feeding. Now, most therapists, when they read this part of the manual, they want to tear out those pages. I don't want to do that. Thank you very much. I do not want to be having any meals with these kids and their families. And it's true. I have had food thrown at me. It's true that my carpets have to be cleaned sometimes. However, if you're not willing to face down the symptom with the patient and her family, what are you asking them? It's a great opportunity to do it. So I've asked them to do a particular thing, and so they have a task, so they're leaving with something to do, and I'm going to see them fairly soon. And I think actually that they trust me. I have a sense that they'll come back, but we'll never know because we have no opportunity to do that today. But thank you very much for your role play. Can we thank them? And I guess we now are open for questions. I don't know if you guys can go back down. And maybe Daniel, you want to come up and we'll take our final questions from here.
I think the family was a great example of a low EE, low expressed emotion family. That doesn't mean it's going to be easier just because they seem so well behaved, but and as you pointed out, I think it's often more tricky to work with a family where the adolescent is so seemingly coming along with all the difficult things you have put in front of them. And it was especially telling when you instructed the parents about the meal that they need to bring next time around, and the patient sort of nervously backed off and looked at her sister and just smiled and go, "Oh my gosh, what does that mean?" And I think that's a very typical reaction to either in this. What do you call it? A good kid?
Yeah.
Because I always say that they are kids who just show their fury with you by not talking to you, and you can clearly see they're very angry and upset. You get those who are belligerent and tell you that they're very upset, and then you get the Mayas who are very collected. But I don't think as a clinician you should be fooled one bit that Maya doesn't have the same resolve as the very angry or the very belligerent adolescent.
No, she's lost 15 pounds in 4 months, and her parents, she's not responding to interventions, and she's denying what the doctor had to say. She's not going to fool us very long. And as soon as the meal is put there, we'll see.
Right. So now you go on to the second session where you do a family meal where if you achieve two things, it would be to just learn how this family puts themselves together around eating, which means who buys the groceries, who prepares the food. Is the patient in the kitchen all the time? Has the patient taken over cooking? Does the patient hover over the parent who's doing the cooking, making sure there's no oil, no butter in the pasta sauce? Who brings the food to the table? Are there meal times? Do they have meals together? So you're looking at both the setup and the structure and what it is that enables them potentially to do an even better job at taking care of their kid, and what are the kinds of things that trip them up. And then in the second part of the meal, you try and give the parents an opportunity to convince their child to eat more than she or he was prepared to eat. And that's a very kind of broad statement. It might mean that she's eaten adequately in the session, sort of, but you do want to see the parents attempt to get her to eat even more. Or the other side of the spectrum, she's eaten absolutely nothing, and you're just trying to get the parents to convince her to eat at least one bite of whatever it is that they put in front of her, and everything sort of in between. So that they can walk out of there, you having a good understanding of how this family organizes themselves around meal times. Are they even there to provide the meal, the context for this to succeed in, and how you're going to maneuver that for them? And the second piece is to, perhaps for the first time in months or years, for the parents to feel that sense of accomplishment that, my gosh, we could actually get her to eat more than she wants to, and we haven't been able to do that despite all our pleading and efforts at home. And the final piece is you really want the adolescent to walk out of there not feeling completely bamboozled by everyone else who seems to be on her case, that you really empathize with her for the predicament that she finds herself in, and that you truly understand. You can't get inside her head and know what it really feels like, but you truly understand what it must be like for someone who doesn't want to eat anything and doesn't want to gain an ounce, and you've just engineered these two parents to embark on this course that's going to swing everything that she has worked so hard for on its head. So you really wanted to walk out of there not feeling defeated. And then for the remainder of the first phase, you, in a very sort of not pedantic, but a very structured way, inquire about the way in which these parents are going about providing the food, putting it in front of her, and making concerted efforts to convince her to eat what they put in front of her. And you shape that behavior all the while putting the solutions in their lap so they can come up with it themselves, rather than you telling them what to do. And just one quick example of that is that if you've made a calculation that she probably is eating X number of calories now and still not gaining weight, then there's a lot of psychoeducation. So you explain to the parents that a starved body will need a lot of calories, at least initially, to make that happen. And so even though she's getting about 4,000 a day, if you convince that there's no excessive exercising, there are no other ways that she might be getting rid of the food, they may have to add a bit more to that. Now, you may have a number in your head, but you're just thinking roughly of what it is that they need to add at each meal to achieve that goal. So from what she's doing for breakfast, but the parents are helping her for breakfast, you say, what can you add to that? You don't say add 300 calories. You don't say add a bagel. You say, what can you add to that? If the parents feel themselves at sea, they may say, oh, we don't know, you tell us. Don't tell them. But don't leave them at sea either. So one example would be to say, well, many families find themselves in that position. So for some families, it works if they add a bagel. Others find it works if they add a tub of regular size yogurt. Others may find adding a milkshake. What would you think will work for your family? So let them pick what you've put in their lap so they can own that next step. You may like bagels yourself, but they may be a family who goes, what are bagels? We don't care about bagels. And you've just given them something, and them being polite, they'd say, yeah, sure, okay, and they walk out of there and go, we're not going to do that. So you delicately figure out a way to help them find the answers. And so you work your way through the first phase of treatment like this, very carefully working towards increasing the caloric intake, tightening the ability of the parents to plug all the holes that the eating disorder has created, through which the adolescent can escape not eating, all the while being very supportive of the adolescent and coaching the parents to provide that support, even though they are the ones who persistently make sure that she eats the amounts of food that they think would be adequate for her to begin to gain weight.
The common problems that we see in phase one are the parents aren't in agreement in the strategy that they want to use. So one parent may want to use a particular strategy, and the other parent will say, I think that's terrible, I'm not going to do that. Another area of difficulty is if you might have a sibling that is actually fighting the whole process and is mad because the parents are paying attention only to the sister or the brother with anorexia. Another common problem that you have to think about is how they're going to manage their work times and their schedules in order to make sure that she or he is eating enough. So they have to think about it almost like a kid who needs medicine every 2 to 3 hours, and if they think of it that way, then they can say, oh, well, someone has to make sure she gets her medicine or he gets his medicine at a certain time. So there's the structural problems of monitoring. Over-exercise, when that's happening, a lot of times you have to think very carefully around how they're going to manage that, because kids will do exercise at 2 in the morning when the parents are asleep. I mean, there's a lot of things that the parents need help with learning about the tricks of the anorexic trade. And they can't learn them all at once. They have to learn them a bit at a time. And they, as Daniel put it, plug the holes. And when they do, gradually things start moving in the right direction, and not gradually in one sense and gradually in another. Their weight gain usually starts to correct. There's a lot of wobble at the first several weeks because people are just learning, but after that, they start making progress. So you could think about phase 1 as a learning by doing, but you're providing the support for their learning and they're doing the doing. And it's a very, you get a lot of feedback every session. There's a weight chart. Did she gain weight or did she lose weight? What did you do? Did you think she would? Why did you think she would or wouldn't? Well, we knew she wouldn't because we let her go on a run. We knew we shouldn't have, but she was so upset about having eaten something that she was just bawling, and we just said, okay. We gave in. We shouldn't have. So there's a lot of that kind of learning that you don't judge. You just move through.
So once you've helped the parents to have things kind of together, there's no such thing as a perfect way of managing this, but by the time a good 10% of lost weight have been regained, as we said earlier, you get to the point where the adolescent is now around 90% of ideal body weight. We talked a little bit about how increased glucose on the brain also have an impact on the way one thinks and feels and behaves. And so the adolescent is less combative around not eating. The parents feel much more accomplished than they did at the outset of treatment. And you're now ready to hand the control over eating back to the adolescent. This is the only domain in which you've allowed the parents to temporarily take charge of. Any other aspect of adolescent development should be age appropriate and in the way the family prefers to raise their children. If they think it's fine for her to color her hair purple and they're all cool with it, then that's fine. That's not an area that should be interrupted at all in terms of adolescent expression of self, choice of music, choice of friends. The appropriate parental guidance around these issues have stayed in place, but only curtailed insofar as running around with your friends during phase 1 would not be appropriate because that would be burning of energy that the adolescent can ill afford. So now you move into the second phase and you help the parents to very delicately hand the control back as we said earlier, in a way that would guarantee that they continue to move weight gain forward. Because there's no such thing as ever achieving ideal weight in adolescent treatment, because by the time you end a treatment and the adolescent is at his or her ideal weight, they might be 14 and have 4 more years of healthy growth and weight gain ahead of them. So there's no such thing as reaching a target weight, a temporary target weight perhaps. So weight gain is part of every phase of this treatment. So phase 2 is handing the control back in a stepwise fashion, which might mean that if every meal is under the parental watchful eye, you may start out with the adolescent preparing her own breakfast on Monday under parental supervision. And if that goes well, then she can do so again on Tuesday. If it doesn't go well, then the parents are just back in charge on Tuesday until they see you again. So you don't give them a whole week to experiment and things go wrong, and then she's 2 pounds less than she was the week before by the time they see you again. So you just very gradually help them to continue to feel confident and hand things back only as is age appropriate, so that by the time you get to the end of phase 2, the adolescent is back on track to some degree with where an adolescent of that age should be, which might mean in practice she can go to the mall for a meal and movies with her friends once a week, or there's a sleepover on the weekend with one of her friends. But not without the parents checking in with the host family to make sure that things go okay. And that's how you walk your way through the second phase of treatment. And then by about the 4-month, 5-month mark of treatment, you step into phase 3, where the eating disorder in the ideal case is more or less out of the way, and you help the parents review adolescent development insofar as the age of the patient. If she's 13, then that sits ahead of them. If she's 17 and has been ill for 4 years, then anorexia has interrupted that development for 4 years, so you kind of mourn the loss of that experimentation opportunity, but now jump back on track, and how will the parents support him or her to get back on track, and what are the remaining developmental tasks for this adolescent to embark upon, with two very competent parents at hand now to usher their child through whatever dilemma, eating disorder or otherwise, might come their way. So it's not an intensive therapy per se, or the start of a new phase of therapy, so to speak. It's bringing things to a close and look at where the family might be at to usher their teen back on track with his or her adolescent development.
Yeah, if it's 2 or 3 sessions typically. And one of the things that we would say is if at the end of those 2 or 3 sessions there are dilemmas of adolescent development that need to be dealt with, that would be a different therapy. We would not want to confuse it with this very specific treatment for anorexia. So this is a termination phase, it's a consolidation phase, not a initiation, as Daniel said, of a new kind of therapy. We know we couldn't illustrate everything in this little day with you. I mean, it's not even a day, it's a little less than 4 hours. So, but we have about, I think,
A minute.
a minute for questions.
We just have constraints at the airport called a flight.
I'd just like to know, do you include younger siblings, like 3 or 4 years old?
So
Because a lot of them-
typically,
or you have an age that you...
typically we let the family decide who they bring, and if they are not a management problem, they bring who they want. But there can be a variety of reasons why a younger sibling isn't appropriate. They can't get much out of it. They're bored. On the other hand, there are 3-year-olds that are wonderful in sessions and will go hug their sister or brother and participate in a way as part of the family. And you can learn sometimes. There was one family I was supervising. There was a 3-year-old in the family who just ran the family. I mean, he was all over the table, and no one could focus on her because he was constantly demanding all the attention and wreaking great havoc.
And rest assured, he probably does that at home, and you need to see
Yeah.
that.
So,
That's
but
very helpful.
it's pretty
Yeah.
flexible, let's
Oh,
say.
yes, it is.
One more question,
Yeah.
and we have to run. If you still have a question.
What do you do when you get food thrown at you?
You duck.
Can you throw it back?
No. So all the time, that what you're trying to do, I think, and help the parents realize also, is you're modeling a non-response to anorexic kind of behaviors and debate, whether it's arguing about calories or fat grams or throwing food or whatever. You don't get into the debate. The idea is to have a really clear head about what the goal is and not responding. So when that food was thrown at me in that family meal, for example, I'm thinking of a specific example. You know, this was such a telling moment for the family. It so externalized the illness for them because they realized their daughter would never throw food at a doctor if she was well. That was just completely off the complete curve of anything that they could ever imagine their daughter, who was 15 at the time, ever doing. It really revolutionized their sense about what they needed to do. So I asked, well, what do you want to do? She just threw that omelet that she was supposed to eat at me, which they said, well, we've got the lasagna here. And then
We have a lasagna here.
We have a lasagna here, and she'll be having that, which she should have been having anyway. So you can use it. You know. Thanks so much.
Thank you, guys.